and anxiety. So as we work to treat these people and we address the psychology, I think that we could do that with some relaxation techniques, consider meditation. I think this would be a very interesting time to revisit breathing or crocodile breathing. When we look at manual therapy, this is where we're going to introduce our Graston Technique therapies. And I think we could also consider manipulation as well. And then our therapeutic exercise. Initially, we may consider doing more isometrics for not only strength and endurance, but also for pain modulation, but then eventually reps and sets so that we're getting endurance, strength, and motion. We want to remember that this is a joint and motion is definitely lotion. And then odontology, we might need to get some assistance from our friends in the dental field regarding the various intraoral orthopedic devices. At Graston Technique, I love that we say time spent in assessment is time saved in treatment. And so to truly be Graston Technique therapy, we're going to need to do some type of an assessment followed by the unique treatment stroke. So at Graston Technique, we have 6 instruments, and from our module 1, we have 8 very individualized strokes, following that up with some type of therapeutic exercise, and then going back and reassessing. Did we do the thing that we said we were going to do? Those things together are our Graston Technique therapy. So let's look and see what would our assessment of this TMJ actually be. So the first thing that we want to look at is the opening of the mandible.
Best way to kind of describe it, it's kind of a, it's a theoretical model, so there's some evidence to support kind of all these. And the main one there that I want you to focus in on is number 2, where it says increased fiber tension. So increased fiber tension is probably the start of all of this cascade that could happen. And then we have to ask ourselves what actually causes increased fiber tension. And if you've taken any Graston Technique courses, we talk about this definitely in our advanced course. We dive into it very substantially in our advanced course, a little bit in our essentials course, but prolonged motions or repeated motions and prolonged positions really can cause increased fiber tension. And how we assess those and how we look at those is kind of, I'll leave it to you and other models to kind of decide that. But that increased fiber tension could then cause what we find as local hypoxia. And then when we have local hypoxia, we get a taut band. We can get some tissue distress, where the theory is that there's reduction in ATP within that area. There's blood flow restrictions within that area. And that basically causes a lot of sensitizing substances to stay in that local area. So if you have a lot of sensitizing substances in an area, it causes the threshold of depolarization to happen a lot quicker. Therefore, you're going to get a perception of pain, or at least a pain signal being sent to your brain. And then your brain has to decide what to do with it. So that's where pain gets generated, is from those sensitizing substances. At the same time, within the sarcoplastic reticulum, you do get some calcium release that then causes the increased fiber tension to even be propagated even more. So that's where that cycle kind of goes along, where you then further your increased fiber tension within that area. And then what do people try to do to get rid of this? Well, they try to stretch out fiber tension, which if obviously you're treating people